Hi, my name is Dr. Stephen Flamm, Professor of Medicine and Chief of the Hepatology Program at the Northwestern University Feinberg School of Medicine. As many of you know, there have been dramatic advances in the treatment of hepatitis C virus infection in recent years, such that we're now talking about eradication of the virus in certain countries around the world. The new regimens are so good, pan-genotypic, efficacious, tolerable, that to my knowledge, there aren't even new therapeutic drug development programs ongoing anywhere in the world. And yet, there are reasons to continue to generate data for treatment of hepatitis C in various important subpopulations. One such subpopulation are the elderly, people 65 years of age and older. Why is this an important subgroup? First of all, more and more patients that have chronic hepatitis C are in this age cohort. Many of you know of the new screening recommendations for hepatitis C, such that people born between the years 1945 and 1965 should be screened for hepatitis C, because a preponderance of people in the United States, at least, that have hepatitis C were born in those years. And that means that many, many people with hepatitis C in the United States are 65 years of age and older. People older than 65 or 65 years of age and older also have many medical comorbidities. They may have mild renal insufficiency. They're on often many medications that conceivably could have drug-drug interactions with hepatitis C antiviral therapies. These are all of the reasons that constitute why we need to look at response rates with the various antiviral regimens for hepatitis C in this age group to make sure that the efficacy is similar and that the tolerability is similar. Because of this, I have a poster presentation at DDW this year that investigates this issue, looking at the response and tolerability rates in patients 65 years of age and older compared to under 65 age with elbasvir and grazoprevir. And this investigation looked at patients with genotypes 1 and 4. What we did was we looked at 12 clinical trials in the phase 2 and phase 3 treatment program that led to the approval of elbasvir and grazoprevir for patients with genotypes 1 and 4. We looked at the groups that were treated with 12 weeks of elbasvir and grazoprevir alone, and this was almost 2,500 people. It turned out that 339 people were age 65 years of age and older, and more than 2,100 were under age 65. In addition, the vast majority of the patients were genotype 1, but there were slightly more than 100 patients that had genotype 4. When we looked at the efficacy rates in people aged 65 years and older compared to under 65, they were almost identical, just over 95% SVR for genotype 1 for both groups. There were only 5 patients older than or 65 years of age and older with genotype 4. They all achieved SVR, 100%. When we looked at tolerability in this large patient population, we also noted that serious adverse events, discontinuation due to serious adverse events, and other tolerability-related issues were statistically equivalent between patients age 65 years of age and older and under 65. What we learned from this is that age should not be a barrier to treatment of hepatitis C with elbasvir and grazoprevir in patients with genotypes 1 or 4. And despite the fact that patients age 65 years of age and older were on many more drugs and medications, including acid suppression medications compared with people under age 65, despite the fact that the older patients had more medical comorbidities than patients under age 65, they did equally well. So it is my hope that when we see patients in the clinic, that age is not a deterrent to treatment of hepatitis C. These patients benefit from the product and they tolerate the product very well. Thank you. And I'd like to thank the Chronic Liver Disease Foundation for supporting this presentation.